That is slide means high. Today we are now going to start with bronchiectasis. So bronchiectasis, the another airway disease which you are going to encounter in your clinical practice. Uh, s- s- so starting with an index case. So this is a 45 years old male presented with complaints of increased shortness of breath, increased cough with copious amount of foul smelling sputum for 6 weeks, with history of progressive shortness of breath for 5 weeks. Okay, so and then the patient has also a history of hemoptysis on and off, and then history of loss of weight and appetite was also there. And the patient gives the history of previous history of pulmonary tuberculosis, was been treated 6 months for 6 months 4 years back, and the patient is also a smoker. So with this background, so on examination, the patient is ill-looking. Then the clubbing was present. Edema was present on the patient. So as the patient is a chronic debilitating disease, as he is producing more copious amount of sputum, so the sputum contains more of protein, so there is a loss of more protein. So that's why patient has a hypoalbuminemia leading into edema. Okay, so in this patient, so that might be a possibility, or another might be a secondary amyloidosis because of the his previous history of tuberculosis. And then on chest examination, the patient has a bilateral vesicular breath sound with coarse crepitations on the right infrascapular area was there on the chest examination. And CVS and abdomen is unremarkable. So the diagnosis, we made provisional diagnosis as a background of tuberculosis. So tuberculosis might healed with bronchiectatic changes. Okay, so that's why we made this as a case of post-TB tuberculosis bronchiectasis as a diagnosis. So this is the how the typical the presentations of the patient might be, because okay, you are going to get in the case of bronchiectasis. So with this index case, as you know, the okay, I admit got this. So bronchiectasis is defined by a dilatation or ectasia of the airways of the bronchus. So the word is coined by Laennec in 1819 for the ectatic bronchi. So it can be a chronic suppurative airway infection with sputum production, which is leads into progressive scarring, and the lung damage occur, and whatever might be the cause that will come on the coming slide. Okay, so it can be a localized or diffuse. So it can be a localized or diffuse. So coming to the pathogenesis of bronchiectasis, so there is host factors and then the environmental factors and the pathogens all will play a part. So host, it can be a innate immunity response, adaptive immunity, prematurity, early respiratory infections, previous lung injury is the one. So as in our case, it might be a previous lung injury because of the infection, that is tuberculosis. So environment, it can be a toxic inhalants, tobacco smoking, overcrowding, biomass fuel combustion, all these things. And the pathogens, resident microbiota, viral or bacterial infections, repeated viral or bacterial infections causing a repeated pneumonia is also a risk factor. Co-infectious or infections like Mycobacterium tuberculosis, and the non-culturable organisms. In the case of viral in the children, you should also think about the mumps. Okay, so if the mainly measles. Sorry, I'm telling mumps is measles. So measles infection might lead into a bronchiectasis. So that is mainly important. And then interbronchial infections and or injury that may lead into airway inflammation. There is a proteolysis, oxidation. All these will lead to hypersecretion of airway, and there might be a airway hyperresistance. There is an impairment of mucociliary apertures. So all these lead into a airway damage and leading to obstruction, causing increasing bronchiectasis. So this is how the pathogenesis goes on in the case of bronchiectasis. So there is always a vicious cycle in the bronchiectasis. So there is a neutrophilic inflammation leading to impaired mucociliary clearance and the accumulation of the mucus. So this lead into a bronchial obstruction and lung damage and structural lung disease. So all these lead into again a microbial colonization. So this is mainly important. Okay, so we are getting a lot of colonization of the microbial organisms. So this is an repeated infection again leads into neutrophilic inflammation, and this cycle continues. So this is the vicious cycle which is leading into a more damage to the airways, leading into bronchiectasis. So what are the conditions which is associated with the bronchiectasis? So these are the lot of list of conditions. So you can also divide into it as the acquired and the acquired causes and the congenital causes. Okay, so that is given in your division. So this is the mainly uh, um, box which I taken from the Nadal's respiratory medicine textbook. Okay, so it's a condition associated with the bronchiectasis mainly is idiopathic inflammatory disorders that can be associated with sarcoidosis. So I will be going to deal with the sarcoidosis in the ILD classes. Okay, so and then the interstitial lung disease lecture, and the rheumatoid arthritis. Then the ankylosing spondylitis can be also lead into a bronchiectasis. So systemic lupus erythematosus, SLE, Sjogren's syndrome, inflammatory bowel disease, and relapsing polychondritis. So all these are the idiopathic inflammatory disorders which might be associated with bronchiectasis. Then another is the inhalation and obstruction like gastroesophageal, repeated gastroesophageal reflux and aspiration, repeated pneumonia, toxic inhalation and thermal injury, post-obstruction accident, foreign bodies, and then the tumors, benign and malignant, which is causing the luminal blockage, leading into mucus impaction, leading into the bronchiectasis, and extrinsic airway compression that might be also responsible, and allergic bronchopulmonary aspergillosis. Okay, so I'll discuss this in the coming slides. So this is the term that we have to be also very vigilant if the patient is having a allergic bronchopulmonary aspergillosis or not, because of the repeated exposure to the mycosis like aspergillus. Then the miscellaneous other are the HIV infections, AIDS, Elonel syndrome, radiation injury, and lung fibrosis, and the post-infectious conditions like childhood lower respiratory tract infections, granulomatous infections like tuberculosis, necrotizing pneumonias in adults, and other respiratory infections also lead into bronchiectasis. And then for the congenital factors like primary immune disorders like humoral defects, cellular mixed disorders, neutrophilic dysfunction, and the other. So this might be a primary hyperglobulinemia syndromes are the things that you have to consider. And another term is the cystic fibrosis. Okay, so in the Western world, we are going to get the cystic fibrosis, but in our part, so we are not getting so much of cases of cystic fibrosis. It can be a classic cystic fibrosis, parents of cystic fibrosis or Young syndrome, and the another is alpha-1 antitrypsin deficiencies and anomalies, and the other heritable risk structural abnormalities like primary ciliary dyskinesia, Williams-Campbell syndrome, Moran-Kuhn syndrome, Marfan syndrome, Arcadian syndrome, and then the Marfan syndrome, and sequestration, agenesis, hyperplasia, and dwarfism. All these are the list that will going to complete. Okay, so and for the carcinogens, you have to look for whether there is patient has a sinusitis, dextrocardia or not, or infertility or not. So these all are the syndromes that be associated with the bronchiectasis. Coming to the classification, so it's mainly a classified according to the CT findings or the gross findings of the bronchioles. So it can be a cylindrical bronchiectasis, like it might be a cylindrical bronchiectasis with characteristic signet ring. Okay, so symmetric appearance can be there. It's a signet ring, so just like a ring. Okay, so this is a signet ring appearance can be there. And another one is a varicoid or varicose bronchiectasis, diagnosed in the in this like this varicose. Okay, so it's mainly a varicose, like a varicose vein like thing is there. Is this is the line which is dilated bronchus, which you can see here. And the another one is the cystic one, the cystic, the lot of cyst like thing that you are going to see in the section of the CT scan of the chest. So these are the cystic, so cystic bronchiectasis. So these are the classification of bronchiectasis. So coming to the clinical features. So what are the clinical features? The patient can present with a chronic cough, which is daily and persistent. So this is the box which is from the your Davidson. So patient can present with a chronic cough with daily sputum production with which will be persistent with copious amount of sputum which is continuously prevalent one. And in the patient can also have a pleuritic chest pain when the infection spreads to the involve the pleura, or with segmental collapse due to return secretions. That can be a possibility that you can have a pleuritic pain. And the patient can have a hemoptysis, streaks of blood common, large volumes with exacerbation of infections. And then another is a massive hemoptysis, recurring, requiring mainly a bronchial artery embolization. Okay, so that's the treatment for the massive hemoptysis, in which we have to send for the bronchial artery embolization by the intervention radiologist. Then the infective exacerbations can be because of the increased sputum volume with fever, malaise, and anorexia. If the patient has increased sputum volume, if there is a fever, then the malaise, and then the anorexia, then we can think this patient might have an infective exacerbation of bronchiectasis. And there can be a halitosis, frequently accompanies the prevalent sputum, and there will be a general debility like difficulty maintaining weight, anorexia, and exhaustion, breathlessness will be there. So coming to the signs, so what are the signs of the bronchiectasis? So patient can, on the general examination, you can find the clubbing. So not on 100% of the patient we are going to get in a clubbing. So it's around 40 to 45% of the patient you can get clubbing. On the chest examination, you can have a vesicular breath sound with coarse crepitations. It can be localized in any part of the chest. Okay, so if it is diffuse bronchiectasis, then you can have a diffuse coarse crepitation. Otherwise, it can be localized in any part. So coming to the diagnostic studies for the classification and the management of the patients with the bronchiectasis. So what are the diagnostic routine tests that you can do to prove your diagnosis? So you can do the chest X-ray first, and then you can go with the HRCT chest. So CT scan chest. So if the bronchiectasis is suspected, chest CT, particularly HRCT, is the definitive test to confirm the suspected bronchiectasis. HRCT may help to detect subtle airway dilatation, as we have seen in the earlier slides. Okay, so that's mainly a thing. And also it can also help to identify the esophageal abnormalities also. Okay, so it's the mainly on that. And then the PFTs for patients with significant bronchiectasis, comprehensive PFT include spirometry and bronchodilator responsiveness. We can see long volumes and diffusion capacity are the important studies. So that will help to aid in the management and the prognosis of the patient. And then the complete blood count, you can see for the anemia, which means with the chronic infection or the blood loss considering the inflammatory bowel disorders. Okay, and then the leukocytosis may mark severity of the infection. And then the eosinophilia, which you can get in the case of allergic bronchopleural aspergillosis, mycosis. Okay, so that you can going to get in ABPA. And ESR and CR reactive protein is non-specific marker of very high levels may suggest underlying connective tissue disorders or vasculitis. So that's why we have to think about the other CTDs. Okay, so connective tissue just like SLE, RA, and all these things that we have to do the test in the coming. So we'll discuss in the coming slides. Then you have to send the routine sputum culture. So antibiotic therapy in the bronchiectasis should generally be directed on specific pathogens. Okay, in vitro susceptibility, the presence of mucoid strains of Pseudomonas. So most common is the Pseudomonas. Okay, so recurrent infection. So if the bronchiectasis is there, the Pseudomonas aeruginosa is most likely the organism, and Staph aureus may raise the suspicion for cystic fibrosis. So and then the first Maltofolia, Alcaginaceus, Jalus and Burkholderia capacia are the gram-negative bacilli that may prove problematic pathogen in the patient with long-standing bronchiectasis. So gram-negative coverage should also be there if we have the repeated infection with all these gram-negative bacilli. And the isolation of B. capacia and the Helicobacter requires special laboratory techniques that we have to use for that. And then the Mycobacterium is sputum culture. So because why it is important? Because of MAT. Okay, so only the pulmonary tuberculosis is not there. So the another associated is a Mycobacterium other than TB. Okay, so that is known as MOT. Okay, or Mycobacterium avium complex, MAC complex. Then the Mycobacterium chiloni and Mycobacterium aviceus appear to be increasingly common in the contemporary bronchiectasis. So that's why we have to think about that. If the patient is not improving, if the patient has a low-grade fever, loss of appetite, and all these things, so then we have to send for the Mycobacterium sputum culture and look for the Mycobacterium other than tuberculosis, non-tubercular Mycobacterium tuberculosis that we have to think about, and maybe conventional but often the pathogenic. So fungal, and the another is a fungal culture that we have to look for, is especially in the patient with asthmatic component. In the patient, if you are suspecting of aspergillosis species, or most including this pseudoleishmania or penicillin may suggest the cause. And CT scan of sinus is another important thing that you have to think if the patient is coming of CRS, that is chronic rhinosinusitis, and many may have a bronchiectasis, and patient also suffer from this. And then the presence of extensive sinus involvement, so it's possible cystic fibrosis. Okay, so possible cystic fibrosis, immunoglobulin deficiencies, or ciliary disorders. Also, optimal management often entails the aggressive sinus care. So that's why the CT scan of sinus is also advisable. And to complete the list, so we can do for the ANA for SLE, RF factor for rheumatoid arthritis, HLA-B27 for ankylosing spondylitis, serum IG level for ABPA, or any allergic specific for aspergillus that you can do, saccharine test and sweat chloride test for the cystic fibrosis that you can do for the complete the list of the investigations. So what are the findings that you are going to get in the CT scan? So CT scan is a computer, you can going to get the extensive dilatation of the bronchi and with thickened walls. Okay, so with thickened walls that you can get, going to get with the thickened walls. So these are the thickened walls of the bronchi in the both lower lobes. Okay, so in the both on the lower lobes that you are going to see. So this kind of CT scan. So in the chest X-ray, so you can see these are the honeycombing appearance. Okay, so honeycombing appearance. So this is the middle lobe, right middle lobe bronchiectasis on that. So on the lateral also you can see the bronchiectasis changes, and this is the cystic changes in the CT scan that you can going to see all these kind of changes in the imagings. And coming to the ABPA, so what is ABPA? So it's mainly allergic bronchoalveolar aspergillosis if patient is sensitized to the aspergillus. So you can get, this is the glove in finger patterns. Okay, so just you are putting the fingers in the glove, is just like a globes is just like this finger in globe pattern. So this is because of the mucus impaction in the dilated bronchi. Okay, so mucus impaction, so that you are going to see in the ABPA. So this is the diagnostic criteria which is given by the mycological association in 2013. So the mandatory criteria is IG specific for Aspergillus fumigatus, or a positive skin test against Aspergillus fumigatus can be there, or total serum IG level more than 1000. Okay, so there's another criteria, at least 2 must be present. So IgG against Aspergillus fumigatus, and the radiological changes typical of ABPA, that is in that we are going to say is a proximal cylindrical bronchiectasis, alterations predominantly in the upper lobe, nodules, atelectasis, and air trapping. These are the thing. And the another is a total eosinophil count of more than 500 cells per unit per liter. So if this criteria is met, then we can diagnose this as a ABPA. So the treatment is mainly the steroids and the antifungals like itraconazole or poriconazole or posaconazole that we are going to use for the treatment of allergic bronchoalveolar aspergillosis. So coming to the foremost treatment of bronchiectasis, so foremost and the first treatment is always a airway clearance techniques. Okay, so this is the technique that we have to think about. So it's mainly of just physiotherapy is the foremost treatment always we have to practice for the and advise the patient. Okay, so not only the medication, but the most important is the airway clearance technique. So how to do the Xray clearance techniques. So there is certain. So I want to show you the video. Okay. See. Video आया सब? Can you see the video clip?
sir. Sir.
Hi. Hi. So this is the national NHS from UK. So this is the from physiotherapy side. So one is you can go for the active cycle of breathing. Okay, so this, let's see the video.
This is a short video to show a demonstration of the active cycle of breathing to help clear secretions off your chest. So what we're going to do first of all is I'll talk you through the technique and then we'll run through it together. So first of all, it's going to be 3 deep breaths. So it's going to be a nice big deep breath in, hold for 3, and then just gently out. We'll do 3 breaths, then we'll go to breathing control, which is your small normal breathing, and then back to your 3 deep breaths again. We'll then go on to the huff, which is when we're trying to move the secretions and make them rumble. So the huff is a medium-sized breath in, and as if you're steaming up a mirror or a glass if you were going to clean it. So it's whereas yours will sound grumbly. Right. And then after, you're going to keep doing the huffs until you feel the urge to cough. And then you're going to cough and clear any secretions that are there. Right. Okay, so a nice deep breath in when you're ready. Good. And again. Good, and then just some small relaxed breaths. And in your own time when you're ready, go back on to do your 3 next deep breaths. Good. Good, and then back to a couple of relaxed breaths. And when you're ready, onto your huff. Good. Excellent. And now that you've cleared your chest, you're just going to have a few normal breaths and then we'll go through the cycle again. So when you feel ready, your 3 deep breaths again. Good, and then just small gentle breaths again. And your 3 deep breaths when you're ready. Good, your relaxed breaths and then onto your huff. Thank you.
So this is the hopping method, right? So hopping method is this one. So this is the active cycle of breathing. So next
this is a short video to show a demonstration of the active cycle of breathing to help clear secretions of.
So this is the another one is a positional drainage, autogenic drainage. Okay. So this is the another thing that you are going to do.
We're now going to demonstrate autogenic drainage, which is another treatment used to clear your chest. So what we're going to do this time is you're going to start off with a test breath, and with the test breath you're going to take a nice big deep breath in as far as you can. You're going to hold for 3 and then you're going to do your huff out. So you're going to keep doing that huff until you hear the secretions, when you feel the rumbling in your chest. When you feel the rumbling in your chest, you're going to take a normal breath back in and again huff it all the way out until you hear the phlegm. Every time you hear the phlegm, you're going to take your breath back in and huff back out again until you've got the urge to cough. This technique is moving the phlegm up as high as it can to help you clear it out of your chest. I'm going to put my hands on your chest when you're doing your breath in to make sure that you don't take too deep a breath in the top part of your chest. Okay? Okay, right. So I'm just going to place my hands on first of all. So I want you to take a nice big deep breath in. Do your hold for 3 and then do your huff out till you hear that flame. Take your breath in and huff out. Just a normal breath in until you hear and huff out. And in and out. And in and out. And in and out. And in and out. If you need to cough, that's fine.
Excuse me. Oh, sorry.
Okay,
Yeah,
that's fine. So we'll do the same again.
Yeah.
Okay. So when you're ready, nice big deep breath in. Hold it there and out. And breath in. And huff all the way out. Breath in when you hear the rumble. Normal breath in just to there. And breath back in. Just to there. Back in because it's rumbling. There. Well done, and we'll just do one more.
Sorry about that.
Okay. So when you're ready, your test breath again. Hold and out. Remember, make it rumble, and your breath in when you hear the rumble. Breath in because it's rumbling. Remember, your huff out just to there. And just to there.
Very much. Sorry.
Perfect. Well done. Thank you.
So this is the autogenic drainage, okay? And the another one, this is the device. So device, this is the Acapella device, okay? So that's mainly a
We're now going to show you a short clip using the device called an Acapella, which is an oscillatory device which helps clear your secretions. So what we're going to do first of all, I've set the dial to 3, so that's your resistance, and you're going to take a slightly bigger than normal breath in, pop your lips around the mouthpiece and blow out through the machine. While you do that, the machine will vibrate, and it will vibrate into your airways and help loosen off the secretions. We're going to do 5 breaths with the Acapella. Once you've done your 5 breaths, we're going to go on to your huff, which is a medium-sized breath in, as if you're steaming out your mirror. To hear the secretions moving. We'll keep huffing until you've got the urge to cough to clear some of the secretions.
5.
5 breaths, please. So slightly bigger than normal in, and then out through the machine. Perfect. Another 4, thank you. Excellent, 2 more. There. And then onto your huffs. Good. Excellent. Then just have a few relaxed breaths and then we'll go through again. Okay, in your own time when you're ready, your 5 breaths with your Acapella. Couple of relaxed breaths. And then when you start your huffs, remember to keep huffing until you've got the urge to cough. Good. Keep going with the huffs. Excellent. Thank you.
So that's how you are going to do the hopping and method. Okay. So now, this is the mainly a thing that you are going to do is a airway clearance techniques. Okay, so this is how you are going to do the different techniques that you can advise to the patient. Okay, so general all stages. So for all stages, the airway clearance should be there. And the another thing that you have to apply is the vaccination against influenza and pneumococcal vaccine is advised to any patient, and manage other comorbidities and underlying cause. You have to advise for the pulmonary rehabilitation. So that's why the physiotherapist has to be there. And the prompt treatment of exacerbation should be there, and sputum surveillance of Pseudomonas aeruginosa and non-tuberculous mycobacteria. Okay, so you have to send for the mycobacterium culture to look for the non-tuberculous mycobacteria. And then there might be whether to use for the long-term antibiotic therapy, the anti-inflammatory therapy, and the therapies in advanced disease. Okay, so for the mild severity, then the daily physiotherapy is always advised. And for the moderate severity or persistent symptoms despite standard care, you can add on inhaled corticosteroids in certain selected patients because it acts as anti-inflammatory. And then the consider macrolides for the patient with a frequent exacerbation. In this, it acts also as an antibiotic macrolides, and also it acts as a immunomodulator or anti-inflammatory drug. Okay, so macrolides. And the regular physiotherapy plus minus agents of devices, or you can use the hyperosmolar agents in the form of mucolytics. Okay, so mucolytics you can use. And then for the long-term therapy, you can go for long-term oxygen therapy, lung transplantation, and the surgery is the last resort in the severe bronchiectasis or persistent symptoms. So in that, you can also get going with the same regimen that you are going to treat here. Okay, inhaled corticosteroids in selected patient, macrolides for patient with frequent exacerbations, inhaled antibiotics, particular with Pseudomonas aeruginosa colonization, and the regular physiotherapy, adjuncts, devices, and all these things. Okay, so this is how you are going to for the treatment of bronchiectasis. So for the antibiotics, so mainly you are going to use the anti-pseudomonal antibiotics. So you might be known about what are the anti-pseudomonal antibiotics, mainly the quinolones group of drug, in which the ciprofloxacin has more action as compared to the levofloxacin and the moxifloxacin. So you can use the ciprofloxacin 750 milligram BD, or you can use the other aminoglycosides like gentamicin or tobramycin, or you can use the anti-pseudomal cephalosporins like ceftazidime, cefepime, which are cefaparazone, which has been active against Pseudomonas, and then the penicillin group like piperacillin tazobactam, and then the carbapenems like meropenem, imipenem, and doripenem. And also you can use the glycopeptide like colistin and all these things. Okay, so which are been active against Pseudomonas. So first you can try with ciprofloxacin, and depending upon the thing that you are going to use the other drugs. And then the if the patient has a recurrent infection, recurrent gram-negative infection, and the recurrent infection, that you can try for the inhaled tobramycin or inhaled colistin with the recurrent gram-negative organism is isolated. So macrolides, prolonged duration as an anti-inflammatory, you can use the azithromycin 250 milligram thrice weekly, but you have to monitor the QT prolongation is there or not. Okay, so for that you can use the azithromycin for prolonged period if the patient has repeated exacerbations. So indications of a surgery is mainly a localized disease. If there's a localized disease is there, you can consider for the surgery, and the patient is young and there's no any comorbidities. You can try for pneumotomy or lobectomy of that bronchiectatic lobe, that you can remove that lobe and that part. And for recurrent hemoptysis, you always have to send for the patient with a massive hemoptysis there. You have to send for the bronchial artery embolization. So this is the how you are going for the indication of the surgery. So this is how you are going to manage the patient with bronchiectasis. So with this, I am concluding the today's lecture of bronchiectasis. Okay, so read. So it is very nicely given in your Davidson also. So you read the bronchiectasis topic in Davidson. So it is one of the important clinical conditions which you are going to encounter in the medical practice. Okay, in the medical practice in the respiratory disease. So if there is any queries, you can ask. Otherwise, I can stop. Okay. So in next lecture, we'll going with pneumonia. कैसा question, Saru? कैसा बुझ्यो? So in summary, so you should read about the definition, what are the causes of bronchiectasis, okay, so, and the clinical features, and then the what are the investigations that you are going to do for the bronchiectasis, and then the management. In management, the mainly is the chest physiotherapy is the most, and then you can use the bronchodilators in the form of inhaled corticosteroids or the bronchodilators, and then the antibiotics for the recurrent infections. Okay, so antibiotics for the recurrent infections, and then the vaccinations, and the surgery is for the localized disease, and then the for hemoptysis, massive hemoptysis, you can go for the bronchial artery embolization. So that's the summary of the today's lecture. So okay, thank you for your patience. So I am going to conclude. Hey.
Thank you, sir.
Thank you, sir.